Hello everyone. Shall we start?
أهلا دكتورة، خلاص أيوة نبدأ.
Okay. So welcome everyone. It's absolute pleasure to be here again. This is my third turn with the crash course, and I'm truly grateful for this opportunity. Thank you all for taking time and joining us in this session today. So just like sudden thunderstorm that turned the sky dark and wild, endocrine storm can strike fast and often without any warning. Sometimes the patient came initially stable and suddenly in the next moment he is in complete chaos. So what makes these crises so deadly is that they often mimic other emergencies like sepsis, heart failure, or even psychiatric syndromes. And unless we quickly recognize them and treat them appropriately, the patient unfortunately will deteriorate. So that's why over the next 1.5 or 2 hours, we will discuss and explore the most dramatic, dangerous emergencies in medicine: endocrine storm, life-threatening metabolic crisis. And today, we will focus on 3 major categories of endocrine storm: thyroid-related crisis, glucose-related crisis, and adrenal crisis. And those are, I thought, every clinician must be ready to identify them and treat them immediately. So let's dive and uncover how to spot those storm and calm the chaos and save lives. My objective is to review the pathophysiology of major crises, discuss the diagnostic challenges, and outline the management strategies. First, start with the glucose-related crisis. We have hypo and hyperglycemia. Anyone know what is the definition or how we identify hypoglycemia? Feel free to speak up and participate.
Random plasma glucose less than 70 milligram per deciliter.
Okay. Anyone else? So with the symptoms, sign and symptoms, excellent. What else? So that's great. So in order to define hypoglycemia, we have to keep in our mind 2 considerations. The first thing is, as mentioned before, the level of the glucose and how it's low. The second thing is the patient, if the patient symptomatic or not symptomatic. Any patient having symptoms with the level, regardless, sometimes we accept low, higher level of low hypoglycemia in patient like renal impairments or patient with the known type 2 diabetes. But in general, 40 to 70, this is moderate hypoglycemia, which is sometimes in other like unit, we use it at 2.2 to 3.9. And severe hypoglycemia, anything less than 40. And usually the symptoms appear when the level between 40 to 50. As a symptoms of hypoglycemia, it's range. We will discuss it further more in the next slide, but if the patient's symptomatic, that's mean he is in hypoglycemia and we have to treat immediately. The challenge with the symptoms in patient intubated or under sedation. Those patients difficult to recognize or see any symptoms on them. Okay, why is the hypoglycemia is dangerous? Why we care about it? Why we always in each resuscitation you see the physician handling the case, ask the nurse to check the blood sugar immediately in any critical case?
Because hypoglycemia can mimic other cases.
Excellent. Other than this? As you mentioned, it's mimic, yes, but on the other hand, it can cause permanent brain damage. That's why we care about the hypoglycemia, and we need to treat it immediately whenever we identify it. Okay, so what are the causes of hypoglycemia? I will give you a hint. It's a 3 classification, so you will give me the some example. So it's a drug-induced or related to the intake or specific disease.
Antidiabetic medication.
Excellent, excellent. Oral hypoglycemic, yes, excellent. Insulin, yes. Starvation, excellent. Sepsis, yes. So as a drug-induced, we have oral hypoglycemic medication, we have the salicylate intoxication, we have steroids, not a steroid, I mean the hydroxychloroquine or quinine, sometimes the phenytoin and fluoxetine as antidepressant. Lithium intoxication can induce the hypoglycemia. Intake, as you mentioned, the starvation, decrease oral intake, it can induce the hypoglycemia. Specific disease, sepsis, adrenal insufficiency, the renal failure, and sometimes also the myxedema coma. We will discuss it also later. Alcoholic, also it can induce liver failure, yes. So beta blocker, excellent, excellent. So beta blocker also can cause hypoglycemia. Okay, the clinical presentation, as I mentioned before, usually they have the symptoms at the level of 40 to 50, and usually the symptoms, it can be anything you imagine, but to keep it easier to remember, think about the brain dysfunction and autonomic symptoms. So it can be diaphoresis, tremor, anxiety, tachycardia, palpitation, even high blood pressure. It can be nausea, vomiting, hunger. Those are some of the symptoms, autonomic symptoms of hypoglycemia. As a brain dysfunction, it's start from anxious, blurred vision, confusion, stroke symptoms, weakness, slurred speech, dizziness, seizure, lethargy, and coma. So think about the hypoglycemia symptoms as a profound brain dysfunction in addition to autonomic dysfunction. Yeah, irritability and tremor, excellent. Okay, how to diagnose it? Easy. When we suspect it, in addition to the clinical presentation and the history, we do the point of care glucose level. Sometimes we will need to send the blood to the lab just in case we are in doubt of the measurement. But Even though if the patient have a severe presentation, we have to treat and then send the blood level. Other tests to consider is thyroid, liver function, cortisol, because in addition to the septic workup, in order to identify the precipitating cause. The treatment, all of you know it. I'm sure 100% most of you encounter hypoglycemia even during the training or during Hajj. Most of the students, they participated in Hajj volunteering. So hypoglycemia, something I'm sure most of you encounter. So as a treatment, if the patient able to take orally, we will give a carbohydrate dense food. And if the patient is unable, we will give the IV dextrose administration. For the adult, usually 50 ml of D50 water, and we can repeat it as needed. And for the pediatric, we usually use 2 ml per kg of D25 water, and for the neonate or infant, we will use D10, 5 ml. In case of we didn't have IV access, so I will not leave my patient in seizure or in profound coma because of the hypoglycemia while I didn't have immediate access, IV access. So I can use as alternative glucagon 1 to 2 milligram of IM or sub-Q. What if the hypoglycemia is refractory? We can use as alternative the octreotide and steroid. Anyone know how the octreotide work in this case? Okay. Usually, I'm not sure if you are familiar with the oral hypoglycemic overdose management. So one of the management is octreotide, because octreotide, it can inhibit the insulin secretions from the pancreas. And for the steroid, usually it's work about on the sensitivity of the end organs to the insulin. So it make the end organ resistant to the insulin effect. Okay. Let's have this case and let's figure out what the next disorder or next crisis. So a 23-year-old male with the past medical history of type 1 diabetes mellitus present with the nausea, vomiting, abdominal pain. Laboratory workup is significant for blood sugar of 422 and a 9 gap of 26, potassium 3.6, bicarb 11, and pH 7.18. Anyone have idea which crisis? Excellent, DKA. So we are dealing with the DKA. What is the definition of the DKA? Or what is the diagnostic criteria of DKA? Hyperglycemia, yes. Acidosis, ketonuria, ketonemia. Okay. Yeah, so it's a triad. In the 2000, by the way, most of the guideline, they have this statement: there is no perfect definition for the DKA, but the most of the guideline, and especially the last one in 2024, they define the DKA as a triad of hyperglycemia, glucose more than 200, or and keep this in your mind because we will discuss it later. Prior history of diabetes, ketosis, beta hydroxybutyrate more than 3 millimeter, and this is the most diagnostic, or urine ketone. Sometimes we use it as an alternative. Urine ketone is strep 2 plus or greater, and metabolic acidosis. And when we mention metabolic acidosis, it should be high anion gap metabolic acidosis to fit the criteria of DKA. So the pathophysiology of DKA, we have DKA, we have hyperosmolar also. But when we think about the DKA, we have to know that in the DKA, most of the patient with the type 1 diabetes, they have absolute insulin deficiency. That doesn't mean the type 2 diabetes, they will not develop the DKA. So sometimes it's more common with the type 1, but type 2 also, they will have the DKA. So insulin deficiency lead to counter-regulatory hormone activation. It will become excess. That's why it will activate the 3 pathway. The first pathway, it will increase the gluconeogenesis. This will lead to the hyperglycemia. Hyperglycemia will induce osmotic diuresis, which will result in 2 things, is the dehydration and also electrolyte disturbance. In addition to that, the lipolysis. So the fatty acid will be transported to the hepatocyte, and this will induce the ketoacidosis. And the ketoacidosis is the reason why the patient will develop vomiting, and this will exacerbate the dehydration and hemo concentration. In addition to that, the ketoacidosis is the reason for anion gap metabolic acidosis. And with the acidosis, the patient will develop the compensatory tachypnea and chiasmal breathing. And ketonuria is at the end. We say it sometimes it's not accurate and have a limited specificity in the diagnosis. The third pathway is the protein breakdown and lead to the loss of the nitrogen, muscle wasting, and amino acid. When the cases become or the DKA in severe stage, the patient will be in shock, and also having as a part of the shock manifestation, they will have a depressed level of consciousness and tachypnea in addition to that. So when we think about the DKA, we have to think that the DKA is one of the type of the shock. We know the type of the shock: hypovolemia, distributive, obstructive, and cardiogenic. In addition to endocrine shock, which include the DKA as a one subtype, the adrenal insufficiency or adrenal crisis, and thyroid storm. So when we are dealing with the patient with the DKA, when we first look at their vital sign, most of the time they are tachycardic and they have soft blood pressure, if not hypotension. In addition to that, they have a chiasmal breathing and some element of altered level of consciousness. They will develop some of the GI upset, nausea, vomiting, abdominal pain. Sometimes it's like a rigid abdomen, and polyuria, polydipsia. So we have to consider vital sign, to look for mental status, pattern of breathing, symptoms and sign on the initial presentation, and document it. Because any deterioration in the level of consciousness while the patient under treatment or receiving treatment, we have to consider the complication of the DKA. Either the patient have develop a severe acidosis and worsen his condition, or the patient develop a cerebral edema. What are the precipitating factors when we are approaching the DKA and want to treat the DKA? We have to consider what is the precipitating factor. Absolute insulin deficiency or infection, inflammation, pancreatitis or myocardial infarction, ischemia, pregnancy, trauma, surgery, substance abuse or alcoholism, and medications induced. In medical school, I used to use this mnemonic 5 I's. Anyone remember it? 5 I's? Infection, yes. Insulin deficiency, ischemia, yes. Sorry. So ischemia, yes. And inflammation and iatrogenic, yeah. And to be honest, from what I see and also I read in the literature, the DKA can be precipitated by any stress, even emotional stress. It can be induced. Okay, so how we approach the patient with the DKA? First, the history. History is very helpful in addition to the clinical exam, and it can give you a key to the diagnosis. As a lab, in those patients, we will need extended electrolytes, calcium, magnesium, phosphorus, potassium, sodium, because for the electrolyte, they have electrolyte disturbance, so we have to replace it and correct it if abnormal. CBC with differential, if the diagnosis is unclear, beta hydroxybutyrate level will give you a more accurate diagnosis, lactate level, urine analysis to detect any infection, pregnancy test, ECG to look for electrolyte disturbance, ischemia as a cause, septic workup in case of history with the ongoing infection. How to manage? So for the management, we use the same mnemonic of the diagnosis. The diagnosis, we said DKA, so D for diabetes, hyperglycemia, K for ketosis, and A, anion gap metabolic acidosis. So for the management, for D, those patients mostly they are dehydrated and they are in shock, hypovolemic shock. So we will need to give them volume resuscitation. For the K is the potassium level. Based on the potassium level, we will start insulin, or we will hold the insulin based on this on the level of the potassium. The third is A, it's anion gap metabolic acidosis, and we cannot close the anion gap acidosis without giving the insulin. So this is just to simplify it, and then now we will go deep in it. So for the IV fluid, we will start the resuscitation with the mostly those patients will require 2 to 3 liters of IV fluid. So the recommendation is with giving the ringer lactate rather than normal saline for those patients, because they will require a significant volume resuscitation. But in case you are in a hospital that didn't have a ringer lactate, or in a situation you don't have other than a normal saline, use the normal saline, because we have to correct the dehydration and the shock. The second thing is for the volume itself, how much volume we give. Usually it's better to calculate, because those patients are sensitive for the volume resuscitation, so it's better to be accurate volume resuscitation. So we calculate the percentage of the dehydration and also the based on the weight also. But on initial, most of the adult 70 kg, they will require 1 to 2 liter, up to sometimes up to 3 liter. Be cautious with the elderly, with the comorbidity like heart failure. Be cautious with the patient having also renal failure. So how to deal with those situations is by using the ultrasound to guide the fluid resuscitation. So this is as a policy. As an infusion, we use the, if the patient blood sugar reach less than 200 or reach 200, we have to give the patient or add dextrose to the IV fluid. So we add D5 half normal saline or D5 normal saline based on the sodium level at rate of 150 to 250. And our target to keep the blood sugar between 150 to 250. The second line is the insulin. So the insulin is important to close the anion gap, but we cannot use it if the patient hypokalemic. So if the potassium level less than 3.3, we will not give the insulin. First, we will correct the potassium, and then we will add the insulin infusion. And we didn't give any bolus in the as an insulin. Usually we give insulin infusion. And if the potassium level between 3.3 to 5.2, we will give insulin in addition to supplemented with the potassium chloride. If the potassium is more than 5.2, so at this level we have to start the insulin, but we will not start the potassium, but we will follow the potassium level after 4 hours, and our target is to keep it 4 to 5 milliequivalent. Other electrolyte to correct is the hypophosphatemia, avoid hypoglycemia, and to see also the magnesium level, because it's correlated or related to the potassium level. What about sodium bicarb? Anyone having idea when to use sodium bicarb? Any rule in DKA? Okay, yeah. So there is a different opinion about the sodium bicarb in DKA, but the most accurate is usually use it when the pH less than 6.9 and the patient in hemodynamic instability. That means the acidosis compromise the cardiovascular status and the patient become in pre-arrest state. So to prevent the cardiovascular collapse, we can use the sodium bicarb, 150 milliequivalent as a 1 ampule, or you can use it on the other situation if we are planning to intubate a DKA patient, because part of the intubation, a sick patient is resuscitate before intubate to prevent a cardiovascular collapse after the intubation. Other than this, treat the underlying precipitating factor. This is one of the most fundamental point. You have to keep it in your mind and to prevent and close the circle in DKA. Okay. The complication of DKA is either it's related to the DKA itself, the acute illness, sepsis, myocardial infarction, hypovolemic shock, or loss of the airway with the deterioration of the case with the severe acidosis, or even cardiovascular collapse. The second part is related to the therapy, hypokalemia, hypophosphatemia, acute respiratory distress syndrome with the over-resuscitation, and cerebral edema and hypoglycemia with the insulin if we didn't check the insulin. That's why usually keep it in your mind. The glucose level should be checked hourly. The VBG and the electrolyte panel should be checked every 4 hours. And to keep it, even if the patient will be admitted, to write it in your order sheet. Later complication, recurrent or rebound of DKA, non-anion gap metabolic acidosis, vascular thrombosis, and mucormycosis. Okay. Before I'm not sure if you remember in the criteria of DKA, we mentioned the first criteria is hyperglycemia or history of type 1 diabetes, right? So, or history of diabetes. So there is something called euglycemic DKA. So the patient in DKA, but the blood sugar is less than 250. And they have a ketosis, which is a fundamental component of the DKA. When we consider this, when the patient is type 1 diabetes and have symptoms, when the patient having impaired gluconeogenesis related to the liver failure or alcohol abuse, when the patient using sodium glucose transport protein inhibitors, and you have to check the medication of the patient when they came to you, when the patient presenting to you shortly after receiving insulin, and this is commonly we see it in the emergency. Patient start to have symptoms of DKA, so they are afraid to develop a DKA, and before they are coming, they receive their own insulin. So maybe you will have such a presentation. Okay. The speed is okay with you? Or I'm going fast? Okay, perfect. Let's have the third case. A 68-year-old woman with a history of type 2 diabetes present with the confusion. She is febrile, heart rate 105, and on exam she is oriented to person and place only. Her mucous membrane are dry, capillary refill is decreased. Her medication include metformin, metoprolol. Blood glucose is 660. So what do you think is going on? Perfect. So HHS. So this patient having hyperglycemic, hyperosmolarity state, as a diagnostic criteria for it, it's similar to the DKA in somehow, but with the absence of ketoacidosis. So profound hyperglycemia. It's not like the in DKA we said the blood sugar is more than 250 now, or 300. Here it's more than 600. Usually it's profound hyperglycemia. The second thing and important component is the osmolality, serum osmolality of more than 320, and absence of ketoacidosis, in addition to the brain CNS dysfunction. So HHS represent the syndrome of acute diabetes decompensation, characterized by marked decreased mental function that it can progress to the frank coma, dehydration, hyperosmolarity, and hyperglycemia. When we come to the pathophysiology, it's similar and somehow to the DKA, but as you see that there is a sensitivity to the hormone that will lead to absent or minimal ketogenesis. This is why we will not have an ion gap metabolic acidosis and ketoacidosis. But otherwise, we will have the activation of the gluconeogenesis, glucose utilization, and hyperglycemia, leading to osmotic diuresis, the same, leading to a profound shock or electrolyte disturbance and dehydration, and then the hyperosmolarity. When we come to the condition that precipitate hyperosmolar, hyperglycemic state, it's similar to the DKA. So think about the infection as the most common cause, myocardial infarction, renal insufficiency, CVA as a mimic for it, mesenteric ischemia, GI hemorrhage, pulmonary embolism, pancreatitis, severe burn, and hemodialysis patient on hemodialysis or peritoneal dialysis, they are at risk. Heat-related illness, it can induce the HHS, pregnancy and trauma. So it can be coexistent with the HHS, it can induce the HHS, it can be the a complication of the HHS. The management, we will focus on fluid resuscitation. The policies keep it for a shock state or severe dehydration, and be careful with the overload for elderly, for morbid patient, like heart failure or renal failure, electrolyte disturbance. You have to replace the decreased or lights and correct the electrolyte imbalance. Insulin, here the target of insulin in hyperosmolar state is for hyperglycemia. So if the hyperglycemia it's not significant, there is no need to consider the infusion. And as always, find the precipitating cause. Okay, perfect. Okay, so this is the first part, glucose-related crisis. We are done with it. Now we will go with the second part. 60 male, known case of lung cancer, SLE, PE, complaining of severe abdominal flank pain, fever, profound fatigability since yesterday. Unremarkable systemic review. What do you think going on with this patient? Anyone? Perfect. Adrenal crisis. Yes. What attracts you that, what is the key word that make you think of adrenal crisis? Excellent. Fatigability in addition to the past medical history. Yes. So, adrenal crisis. So, in the adrenal crisis, first, let's talk about the physiological impact of the cortisol and aldosterone deficiency on our body. So first, the inflammation and immunity. When we have a normal cortisol level, will suppress the inflammatory cytokines, and when we have a deficiency, this will lead to a fever, malaise, anorexia, and develop the infection. And that's why we use sometimes a stress dose of steroid in case of refractory sepsis as adjunct. Hemodynamic effect. The normal role of cortisol level or cortisol hormone is to support the other and work with the other catecholamine and cause vasoconstriction. If in case of deficiency, this will lead to the low blood pressure shock secondary to the vasodilation. The metabolic effect. The cortisol level is a catabolic hormone that mobilizes the energy during the stress. That's why it stimulates the glucagon release. It's promote the protein breakdown and promote lipolysis, stimulate the glycogen breakdown, and also the gluconeogenesis. So in case of the deficiency, the patient will have a poor fuel metabolism. That's why they will develop the hypoglycemia during the stress. On the other hand, for renal and electrolyte effect, aldosterone deficiency, it will lead to sodium wasting and potassium hydrogen retention. That's why we have the patient, especially the patient with the primary adrenal insufficiency, they will have hyperkalemia, and also they will have the non-anion gap metabolic acidosis. So to think about it, in primary insufficiency, the problem with the adrenal gland itself, it's unable to produce the cortisol level or cortisol hormone or aldosterone. As a compensation, there will be increase for releasing the ACTH from the pituitary gland. In secondary deficiency, the ACTH secretion will be depressed because the problem in the pituitary gland, and that's why, but the level of the aldosterone will be maintained because the renin-angiotensin system is stable. So as I mentioned, when we think about the adrenal insufficiency in general, we have a primary, secondary, and tertiary. So let's think about it like this. First, where is the problem? In the primary, usually in the adrenal gland. So the most common cause is autoimmune and TB, fungal infection, cancer, hemorrhage, or infiltrative disease. When we think about the secondary, so the problem in the pituitary gland. So anything in the pituitary, trauma, tumor, surgery, radiation, immune suppressant therapy, those inducer or stimulator for secondary adrenal insufficiency. For the tertiary, the problem is in the hypothalamus, and usually it's secondary to the chronic steroid therapy. That's why we have to ask the patient and check their medications if they are on the steroids for prolonged use or not. When we think about the cortisol level in the primary, it's obvious there is a problem in the adrenal gland, so the cortisol and aldosterone will be dysfunctional, so decreased. In the secondary, the cortisol level, because the problem in the pituitary, so the cortisol level will be abnormal and decrease. The aldosterone will be normal because renin-angiotensin system is intact. That's why it's normal. On the tertiary, the cortisol level is decreased and aldosterone also normal. When we come to the ACTH, which produced from pituitary, will be high in the adrenal, in the primary, to stimulate, it's secondary to the negative feedback, to stimulate the adrenal gland, but it will be abnormal in the pituitary, in the secondary and tertiary. As a key finding or key sign, usually patient with the primary adrenal insufficiency, they have hyperpigmentation. They are at risk of hypotension more, salt wasting, and hyperkalemia and dehydration. In the secondary and tertiary, they are mostly they will have only cortisol deficiency. What are the common precipitating factors? Any idea? Okay, so if we want to think about it, we will think stressors or medication. As a medication, anyone can, okay. So medication, infections, yes. So as stressors, and general stressors, infection, this is the most common, trauma, tumor, surgery, steroid related, like patient on steroid but missing the doses, or tapering too fast, or stopping suddenly, as mentioned in the chat. Psychological stress, it can induce volume depletion, like GI upset or blood loss or hemorrhage. Pregnancy, because there is increase in the hormone demands. Exercise, especially if intense workout. For the medications, we have some of the medication can suppress pituitary gland or adrenal gland signal and reduce the cortisol production, such as common drug is opioid. Other than this, etomidate, yes, excellent. So etomidate, one of the medication, we use it for sedation, but in case of suspected adrenal crisis, we have to avoid it, or in patient with the severe sepsis, we have to avoid it. Other than this, anti-seizure, carbamazepine, phenytoin, phenobarb, TB medication, rifampicin. How to recognize it? So the cortisol, the patient will have fatigability, hypoglycemia, GI upset. They will have some skin and hair abnormality, muscle and joint pain. As aldosterone, it will lead to the dehydration, hyponatremia, hyperkalemia, salt craving. As androgen, low libido, and gonadal failure. But for the adrenal crisis itself, it's the hallmark is a triad of the profound fatigue and fever, unexplained fever, and unexplained or refractory shock. Additional symptoms is the GI upset and delirium. Excellent. So hypotension, hypoglycemia, hyponatremia, hyperkalemia. As a laboratory, we mentioned it before, refractory or unexplained hypoglycemia, hyponatremia, hyperkalemia, non-anion gap metabolic acidosis. So whenever you have a patient look sick, in shock, and you start the management and resuscitation, and the patient hypoglycemic have a significant electrolyte disturbance, having precipitation factor like sepsis, you have to consider the adrenal crisis as one of the causes. Any diagnostic test can be helpful. We have different or variety of the test, but the two tests commonly used, although it's not used or we will not follow it up in emergency unless the patient will be boarded for long time in the emergency. Usually the endocrinology and internal medicine, they are the one to look at these tests. So, but we are the one to order it. Okay, so we have random cortisol level. If more than 20, we exclude the adrenal insufficiency. If less than 5, this is strongly suggest adrenal insufficiency. If less than 20 and more than 7, that non-specific, then we will go to the second step, which is the ACTH simulation test. The ACTH stimulation test, we will inject the patient with the 250 mic of ACTH, and then we will measure the cortisol level at baseline and at 60 minutes. If the cortisol level start to raise to more than 18, this is rule out the adrenal insufficiency. If fail to reach more than 18, this is adrenal insufficiency likely, but if raise of less than 9, this is suggestive of adrenal insufficiency, and we have to do further testing. Additionally, the imaging, usually we didn't need imaging in emergency, but as an additional test, adrenal CT to detect the infection, infiltration, malignancy, or autoimmune disease, and MRI for pituitary causes. But this is just to keep it in your mind, especially for the patient with the first presentation unknown diagnosis. Okay, sure يا Khalid. How you want to do it when you will return? I'm not good in timing. بالنسبة للصلاة طيب ترجعوا 6:15. طيب تبغوا ايش رايكم بس اكمل بس المانجمنت؟ خلاص اكمل المانجمنت وبعدها يصير كل احنا نروح، ما راح اطول عليكم. طيب قول لي، تفضل. Okay. So as a treatment, we have a 5 as a goal, 5S. Correct the electrolyte and prevent hypoglycemia, steroid replacement, and don't forget the steroid or stress dosing, supportive care, and search for underlying cause. So as a resuscitation, they will require a fluid resuscitation, and you have to prevent and correct the hypoglycemia. In case they need a vasopressor for persistent hypotension, you have to add it. For the steroid, if the patient known adrenal insufficiency, you can start with the hydrocortisone 100 milligram. This is the stress dose, and then the admitting team will continue with the 50 milligram IV Q6 hour. If the patient is unknown, but you are suspected this patient adrenal insufficiency, you have to use the dexamethasone 6 milligram IV. Because dexamethasone, it doesn't interfere with the cortisol testing. And as we mentioned before, this testing is required to make diagnosis for the patient with the first presentation. The third is treat underlying cause as all crises we mentioned, and don't forget to rule out missed diagnosis or other diagnosis. Sometimes this presentation is similar to the thyroid myxedema coma, or similar to the cardiomyopathy, or similar to the sepsis. So always consider and rule out other diagnosis. Okay. نروح نصلي ونرجع. We give it in case of hyperkalemia. This is good question. So for the fluid cortisone, we give it in case of hyperkalemia. So let's go to نروح نصلي، ناخذ بريك ونرجع 6:15 مناسب. اوكي بيرفكت، خلاص 6:15 بإذن الله. يعطيكم العافية. Okay, can we start? Okay, so a 16-year-old female present to the ED complaining of fatigue, poor sleep, and anxiety. On examination, you find out she has been losing weight, has dyspnea on exertion and palpitation. Her temperature is 38.5, heart rate of 135, and respiratory rate of 16. The blood pressure of 170/90, and her oxygen saturation maintained 100%. Her physical exam is remarkable for bilateral proptosis, anterior midline neck mass, and resting tremor in both hands. So any idea what's going on with this lady? Okay, I think you figured it out. It's the thyroid storm or thyrotoxicosis. But first, we have to differentiate. Anyone have idea what is the difference between hyperthyroidism versus thyrotoxicosis versus thyroid storm? Fever, confusion, high temperature, GCS. Okay, these are manifestation and good manifestation. But what about hyperthyroidism versus thyrotoxicosis?
I think thyroiditis is the general state, but hyperthyroidism is a specific type of thyroiditis.
Sorry, I didn't hear you.
I think this one is thyroiditis general state من نفس الثيرويد هرمون، لكن الهايبرثايرويد
Okay.
specific type من الثيروسكوسيس.
قريب. Anyone have other thoughts? Okay. Hyperthyroidism is the condition caused by overproduction of increased circulating hormone, thyroid hormone. So the problem in the gland itself. But thyrotoxicosis, it's the hypermetabolic state secondary to the high thyroid hormone. Okay, sometimes the thyrotoxicosis may result from the condition not associated with the hyper functioning of the thyroid gland. كأنه التhyrotoxicosis is the subtype of the hyperthyroidism. Okay, and when we talk about the thyroid storm, it's totally different. It's about the manifestation, as you mentioned in the chat. So the thyroid storm, it's when the patient have a life-threatening cardiovascular, neurological, or GI manifestation. Those type of the patient we know that they are in thyroid storm. Okay, so in the thyrotoxicosis, we speak about the hypermetabolic state resulting from the level of the thyroid hormone circulating in the our body and the effect of this high level. Okay, I hope you get it. So the thyroid storm, although it's the most severe presentation of the hyperthyroidism, but it's misleading sometimes because it's mimic the other presentation. That's why we have to consider it in some of the situation. Like patient known hyperthyroidism and came with the acute deterioration. And this is obvious, we have to consider it. But what if the patient have new atrial fibrillation or dilated cardiomyopathy and he or she is young age? We have also to think about it. Patient with the neuropsychiatric illness or symptoms came with the acute agitation, delirium, acute psychosis, and the patient tachycardic or febrile. In addition, we consider usually the CNS infection. We have to consider also the thyroid storm. When the patient presented with the hyperthermia and the situation or the history is not indicate it's heat-related illness or it's not related to the medication induced, we have to think about also the thyroid storm. When the patient look ill and septic appearance, but there is no clear source of infection, we have to think of the thyroid storm. The triggers, like other storms, always there is a trigger. It's not come by itself. It has to be some factor induce this crisis. So the most common is the infection. The other include the surgery or trauma, preeclampsia, some of the medication like acute iodine, the aspirin intoxication, tyrosine kinase inhibitor, immune suppressant therapy, and also the metabolic stress like hypoglycemia or the diabetic ketoacidosis. The clinical presentation, I want you to think about thyroid storm present as a multi-organ hyperactivity. So the heart bumping or racing and the brain overstimulated. The patient have a fever or hyperthermia. There is a GI upset, and there is a liver injury. There is one of the manifestation is also hematological dysfunction, and patient can develop DIC. But the most common presentation is a cardiac or cardiovascular symptoms. So the patient will come with the tachycardia, in shock state, heart failure, or sepsis presentation. In addition to the neurotype presentation, like acute psychosis, acute agitation, when you see the patient, sometimes you will think about the meningitis, encephalitis, and hyperthermic state. The other manifestation is the symptoms and sign of thyrotoxicosis or hyperthyroidism, the weight loss, the tremor, the goiter, the exophthalmos. These also support your diagnosis, but the most common is the cardiac presentation. On the diagnosis, so on the diagnosis, to make the diagnosis, mostly it's a clinical diagnosis, and it's diagnosis of exclusion. And if the patient known hyperthyroidism, this would make it at the top of the list. But if the patient unknown to have hyperthyroidism, it's like a diagnosis of exclusion. You will go through all the diagnoses that give you this presentation. So thyroid panel, glucose, extended electrolytes, liver function test, coagulation profile, creatinine kinase, because those patients can develop rhabdomyolysis. And for sure, if you think if the patient came with the thyroid storm and having fever, and on the initial presentation you are thinking about the sepsis, so if you consider the infection or sepsis and suspected infection, you have to consider the septic workup and empirical use of antibiotics. And don't forget for the altered level of consciousness also to order the CT to rule out intracranial pathology. What it looked like, the labs, the TSH will be on the lower side, the T4 will be high, and T3 will be disproportionately higher than the T4. In addition to that, sometimes those patients secondary to the stress response, they will have hyperglycemia, liver failure, they will develop a DIC at the late stage. The WBC count, to be honest, it's not, you cannot depend on it. Sometimes it will be low or high, so it's not specific or sensitive for this diagnosis. There is, because the thyroid storm is critical, has higher mortality and morbidity. In addition to that, it's difficult to early recognize, especially when we consider heart failure, we consider sepsis, shock state, other diagnoses. And if it's this patient present for the first presentation as a thyroid storm, that's why they develop something called a Porch Ward-Foskey point scale. This scale, it's not intended for rigid interpretation, but it's to have a systemic evaluation of the patient and not miss such a critical diagnosis. The component of this score, it's include the temperature, the cardiovascular function, the heart failure, the CNS dysfunction, the GI and hepatic dysfunction. So if the patient have a score of 45 or more, this is highly suggestive of thyroid storm, and you have to act fast in order to stop this storm and treat patient rapidly. For the thyroid storm management, we have a general management or resuscitation effort in addition to a specific directed management. For the resuscitation management, you have to ensure stability of ABC and provide umbilical fluid administration, support the systolic blood pressure with the vasopressor, but be cautious with the vasopressor choice. Sometimes for those patients, we use phenylephrine because the effect on the heart rate. Consider empirical broad-spectrum antibiotic. As I mentioned, sometimes the most common precipitating factor is the sepsis, and common mimics for thyroid storm is the sepsis. Treat the hyperthermia with the acetaminophen and active rewarming, and treat psychomotor agitation with the benzodiazepine or olanzapine. As a directed management, we have to use a stepwise approach, and this approach to be organized, because every drug helps the second drug to work. So we will not choose or give the drugs randomly. Okay, so as a directed management, first, we have to block the peripheral effect of the thyroid hormone with the beta blocker. So to control the cardiovascular status, so you use the beta blocker. Usually we use the propranolol. As alternative, we can use the esmolol because it's fast onset, fast offset, and it's a good, you can titrate it very well. The second is to use something to inhibit the thyroid hormone synthesis. So the second, we will use the probyl thiouracil or methimazole. But probyl thiouracil, it's safe in the first trimester of pregnancy, and on the second or third, we can use the methimazole. The third is to inhibit the thyroid hormone release with the iodine. But usually you give it after 1 hour of administration of probyl thiouracil. The fourth step is to block the conversion of T4 into T3 and block the release of T4 from the thyroid by using the steroids. In some cases, if severe symptom, no improvement with the first line therapy within a 24 to 48 hour, you can go with the therapeutic plasmapheresis. This was published in 2022 as a guide, as alternative for refractory thyroid storm. As an adjunct, you can use the lithium or cholestyramine as adjunct. Avoid non-steroidal, avoid the aspirin because it precipitate or induce thyroid storm. Special situation in the pregnancy, as I mentioned, for the first trimester, you use propyl thiouracil. For the second and third trimester, you use methimazole. It's published that methimazole linked to teratogenicity. That's why we avoid it in the first trimester. In case of congestive heart failure, beta blocker, if high output, we will use the beta blocker. Otherwise, stick with the digoxin and also the furosemide. For the atrial fibrillation, beta blocker is preferable for rate control. Avoid amiodarone. We know that amiodarone, it can also precipitate the thyroid storm. For calcium channel blocker, you can use it as an alternative, but verapamil, it's one of the drug that in case of a critical patient, try to be cautious with use it and avoid it at all. Mostly patient with thyroid storm, the hypermetabolic state, the body will be develop a refractory or resistance to the cardioversion. That's why I try to make this patient first in euthyroid state, and then you can use the cardioversion. The last case, 70-year-old female presented with sleepiness. She had a positive history of dysuria, cold extremities, puffy eyes and legs, with the recent diagnosis of depression. As a vital sign, she had a heart rate of 40, blood pressure of 80/50, temperature 35, respiratory rate 14, and oxygen sat on room air is 92. So what do you think is going on with this lady? Yes, it's hypothyroidism manifestation, but mainly it's decompensated. Okay, so why I use decompensated rather than myxedema coma? So decompensated hypothyroidism is preferable rather than myxedema coma because the hallmark of the myxedema coma or decompensated hypothyroidism is organ dysfunction, and the hallmark manifestation is delirium, not a coma. That's why we try to avoid using of myxedema coma. So we have compensated and decompensated hypothyroidism. In compensated hypothyroidism, the patient have the usual presentation of hypothyroidism, the fatigue, depression, cold intolerance, and hoarseness. Whenever there is a physical stressors, physiological stressors, then the patient become decompensated and develop organ failure. So they will have delirium, hypothyroidism, bradycardia, they can be in shock, and also hypoglycemia. So I didn't get the question decompensated versus coma. Coma, myxedema coma, it's just because of the name. So myxedema coma, it's indicate that those patients will present it in a coma. But if we say decompensated, that means there is a multi-organ failure secondary to this illness. Okay? Sure. So we will continue and then I will look at your questions. Don't worry. Okay. So as a myxedema or as a decompensated hypothyroidism, precipitating factor or trigger event, it can be sepsis, and this is one of the most common, and especially pneumonia, because those type of the patient, mostly elderly, exposure to the called CVA drug effects that induce the decompensated hypothyroidism, MI, GI bleeding, trauma, burn, congestive heart failure. So these, it can be a trigger, and it can be presented as a complication of thyroid decompensated hypothyroidism. The core feature for decompensated hypothyroidism is three things: altered mental status, hypothermia, and bradycardia. And as I mentioned before, the hallmark of presentation is delirium. It's not a coma. Coma, maybe it's one stage at of the decompensated hypothyroidism, but the most common and the hallmark is the delirium. And the type of the delirium is related to the decompensated hypothermia is the hypoactive delirium. In addition to that, they can be presented with the hypotension and volume depletion. They can be presented with the shallow breathing, hypoxia, hypercapnia. They can develop a bradycardia, ventricular arrhythmias, AV block. They can be at risk for drug toxicity, especially when they receive it. Maybe it's interact together, or it will lead to precipitated in their body and causing intoxication. Also, they are at risk for hyponatremia. As a lab, basic lab or basic workup to be done, endocrine evaluation, especially for the people with the first presentation. So you have to consider the thyroid function test, the random serum cortisol, and we mentioned before that adrenal crisis is part of the decompensated hypothyroidism, and each one of them interact together. Septic workup, because the most common cause is the sepsis, and also the sepsis can induce the presented with the hypothermia, confusion, and decrease hypoactive delirium. POCUS, very helpful to look for the new cardiomyopathy or pericardial effusion. As a management, first, we have to identify the goals of the management. So identify treat the underlying disease, supportive care, the thyroid hormone replacement, and also to correct the electrolyte abnormalities. So for treat the underlying cause, the most common cause is sepsis. So empirical antibiotic, consider empirical antibiotic, supportive care, fluid, warming the patient, and use the hydrocortisone, especially we said before, the coexistence of adrenal crisis with the decompensated hypothyroidism. Thyroid hormone replacement, levothyroxine, 300 mic, and also to correct electrolyte abnormality, especially the hyponatremia, and prevent hypoglycemia, and also make sure to have a cardiovascular support, and rule out cardiac or pericardial effusion. Okay. done with the presentation, but I have some challenging cases. I hope you can participate and think about it. It's okay with me if you want to speak, or you will write in the chat. And I'm not sure how Sulafa, you will handle it, because you ask for some cases or question.
Yes, دكتورة.
You ask for some questions, so I will carry it out, or you will take over for the question. I mean the challenging cases. Okay. So I will not share the challenging case. I keep it for you. Okay. Okay. Sure. So with that, I'm done with my presentation. And I hope you get the maximum benefit. And now you can manage the crisis or the storm, an emergency, confidently. Just I will see some of your question. No, I don't think so. For the TSH level be affected due to any causes like medications, pregnancy, cardiac arrest. In cardiac arrest, I will not look for the TSH level that will come after a while. So I will manage this case, but the thyroid panel, it's helpful to make the diagnosis and to facilitate the work for the admitting team. But huge presentation, we have our effort using a calculation and also the point of care lab. For the thyroid panel, sometimes it takes days for some of the hospital. It will not be ready or available for emergency department. That's why we will not build a lot of decision on it unless we can have it rapidly. But mostly it will be for the admin team. I have the cases, but I think they want to share it. They will share it with you later. Or if you want, I don't mind, and I can share many questions later, other question later. Okay, so you want me to share it? Okay, the challenging case. And I will share with you other question according what new question to be presented to the audience. Okay. So let's start. 68-year-old female present to emergency department from home by EMS after her son came to visit. and found her poorly responsive. Her vital sign, heart rate 52, blood pressure 95/54, respiratory rate 12, oxygen saturation 98 on room air. Temperature 35. On examination, she moans to painful stimuli, withdraw from pain, but not alert or oriented to person, place, or time. The pupils are 3, equal and reactive. The lung clear. There are no sign of trauma. Head CT scan negative. Her legs reveal non-beating edema. The son doesn't know her medical history, but he said the mother had similar symptoms in the past when she didn't take her medication. Which of the following laboratory abnormality is often associated with this diagnosis? B or C? Okay. So the diagnosis is yes, it's hyponatremia, but yes. Okay. So it's hyponatremia related to the decompensated hypothyroidism. Okay. A 55-year-old homeless, present with fatigue, weight loss. You note digital clumping, hyperpigmentation. He admitted due to cough, fever, night sweat. Lab show hyponatremia and hyperkalemia. The following additional finding that is most likely to be presented or found. Excellent. So hypoglycemia, and this patient have adrenal insufficiency, mainly primary adrenal insufficiency, related to because he have hyperkalemia, hyponatremia, and hypoglycemia.